Good afternoon, everybody. And I really like to thank the Virology Education for inviting me to take part of this important meeting, which is in CEE, Central Eastern Europe. So I will be talking about today about managing highly treatment experienced patients and what could be the new drug options. I have no disclosures linked to this presentation. This is a key topic to me, so to say, because in the past, at least in Romania, we had a lot of patients who were yesterday children, today adults, and we do have the issue of resistance. Because when we talk about highly treated, highly experienced patients, we cannot talk about it without the resistance and without thinking about limited drug options. So resistance is an important issue, and it can be either present at the time of transmission and or can evolve during treatment with antiretrovirals if you do not achieve complete suppression of the HIV replication. So it is really important to know the resistance, the baseline resistance, because it can have an impact on the long term of the patient. Of course, when we talk about resistance, the mutations are important and they can develop during treatment and can be driven by several causes, like adherence, which is now it's an important issue in the HIV-infected patient, about the drug-drug interactions that may affect antiretroviral drug level, and of course, it's really important the high baseline HIV RNA and the low CD4 count. It's really important when you choose the antiretroviral regimen to choose the right one in order not to exhibit adequate activity against HIV. So we need to choose the right treatment regimen. It's really important to keep in mind that even if today we have single tablet regimens, so 1 pill per day for our patient, it's really important to choose it according to your regional data in order to know the resistance pattern of the patient, in order not to have a failing regimen in the future. So these are really old guidelines, EX guideline recommendation from the time point where we are stick with only 2 PIs that we can use. But I want to emphasize the fact that they are still available and they are really important. We need to use 2 or 3 drugs, active drugs, when we choose a new regimen. We should not add one and wait for the other to add on. So we should defer the change if we do not have at least 2 active drugs available based on the resistance data, except of course with the patient with a low CD4 count where it's really important to do something, not to wait for clinical deterioration, and for whom the goal is to preserve the immune functions through partial reductions of the plasma HIV RNA. So if we do have limited options, we should consider experimental or new mechanism drugs and favor inclusion in clinical trials. And this is available from at least 10 years and is still available at this time point as our patients get older and the resistance gets higher. Of course, the treatment interruptions is not recommended, not 10 years ago, not now in 2020. This is an article that refers to our area and to the fact that we have multiple clades of the virus. These are top virologists in our field, in our area, that got together and saw what is the diversity in the area of the Balkans. They called it a melting pot of high genetic diversity. I can only want to focus on Romania because this is my home country, where we can see the colors of the clade is different from the others. So we ask, will that have an impact on the resistant patterns in the future? It really does, because these are a few of the recent studies. I have chosen a few of them that will report that 78% of the antiretroviral treated individuals had phenotypic resistance, and 51% of them had resistance to 2 or more antiretroviral classes, and even 14 to triple class resistance, which is really high. Of course, the presence of resistance is also present in untreated patients, but it was only found in 44% 6.5% of these patients in the data linked 3 years ago. So according to the all available guidelines, it's really important to test for resistance at the time point of the infections, during the chronic infections, and of course when you have treatment failure. Again, this is an article published last year, which looks at the prevalence of resistance. And it's quite important to look at our area from the point of view of the data available. So here you can see that there are countries with higher level of resistance that goes beyond 10%. Romania is one of the countries that will arise with that number of resistance. Again, resistance has an impact, and when we talk about highly resistant HIV, we talk about strains in the patients. I mentioned that a few years ago we can only had PIs available, and these are part of the background, of the backbone of the therapy. Tipranoavir boosted with Ritona or darunavir boosted with ritonavir or cobicistat are the backbone in the patient that we need to treat with something. We will not go through the whole mutation on this slide, but I want to emphasize that even if we do identify mutation, these two PIs can still work. Of course, when we want to optimize the use of antiretroviral in this category of patients, highly treatment experienced patients, the goal of the antiretroviral therapy will be to achieve viral load below 50 copies per ml after 48 weeks, to maintain immune function and prevent clinical progression. It's really important because if we fail in any of these categories, we will say that is treatment failure. Again, emphasizing the fact that we should use at least 2 fully active drugs, and we will see the list in the next few slides, what will be the available drugs for this category of patients. And if it's not possible to achieve the fully virological suppression, we at least attempt to preserve the immune function, the clinical stability, and of course look for further options. We have multiple drugs that can work in this treatment experienced patients, and we will see in a few slides which are these ones. We started with only 3 classes of antiretrovirals, and we have broadened the spectrum of the antiretrovirals for different classes. And we really need to choose the active drugs for this kind of patients. So the good news is that in July this year, FDA approved a new HIV treatment for patients with limited treatment options, and it's called fostemsavir, which is a new type of antiretroviral medication for adults living with HIV who have tried multiple medication and whose HIV infections cannot be successfully treated with their own therapy because of resistance, of course, intolerance, or safety consideration. So this is really good news for our patients. Started 2 years ago, only in some countries, not Romania, we have approved a new type of antiretroviral medication for adults which are living again with HIV, heavily treatment experienced patients whose HIV infections cannot be successfully treated with other current available therapies. So the multi-resistant HIV, the MDR HIV patients. And we use ibalizumab, which is administered IV intravenously once every 14 days by a trained professional and can be used in combination with other medications. These are just a few of the options for this patient that we can rely today. These slides will highlight the overview of 2020, what we have in the pipeline, and what we can trigger and target for this HIV life cycle. So we can rely on entry inhibitors. There are some new molecules in development in order to block the entry of the virus. We can rely on NRTIs and on the new class of RRTTIs, where we have islatravir, which is available at this time point. We can rely on the new NNRTIs, on the mechanism of action and the fact that can overcome some of the mutation. The new integrase inhibitor like cabotegravir, which is the long-active cabotegravir, and new classes like the maturation inhibitors, the capsid inhibitors, and the REP inhibitors. And you can see on this cartoon. Of course, the monoclonal antibodies are a new class in development, and you can see we have a list of the products that are in development and can be helpful in patients like the one that I have mentioned, highly treatment patients with resistance. This slide emphasizes the new drugs that are in development. We will not go medication by medication. I only want to emphasize the fact that the monoclonal antibodies are really important, as I mentioned on the previous slide, but we do have new classes like maturation and other compounds, as you can see over here, in fixed combination that can help with adding to the patient's treatment. These are the drugs that were received approval or are submitted for approval to different areas, either US and European Union. And you can see that there are drugs in different classes, some of them available in different areas, but we will rely on integrase inhibitors, and we can rely on monoclonal antibodies and also on fostemsavir, which is a GP120 attachment inhibitor. These are the clinical trials. These are the drugs that are available in clinical trials. But as a recommendation in the guidelines, if you have no options for your patient, you can aim and introduce them into a clinical trial in order to look for the best medical judgment for your patients. And from maturation inhibitors to drugs in the same categories that I have mentioned at the beginning, in fixed combination or in different combination, these are the clinical phases that the drugs are, from phase 1 to phase 3. We have development this database. So to sum up, I will say that highly experienced patients with resistance, the resistance is a main focus for this presentation, and the emergence of drug resistance is a major obstacle to effectively treat these patients. We do have to point out that resistance will compromise the outcome from the current regimens and limit further options for our patients. So it's really important to be keen on the adherence of the patients, drug-drug interactions, and fully active regimen for the patient. When we change the therapy, change and aim for fully suppression of the HIV, and we look for multiple active drugs that you can add to your regimen in this category of patients. Avoid the sequential monotherapy, as I already said. Don't add a single drug to a failing regimen, add at least 2 of them. And it's really important to retain the antiretroviral drugs and to get what you can do from the patient's backbone scheme of therapy in order to maintain treatment. So usually these patients are highly treated with a lot of drugs that they will receive daily, but the aim is to keep them alive and look for further therapeutical options. And you can, as you have seen in the slide, in the previous slide, we do have a future in HIV and new drugs. So instead of the conclusions, I may only say that it doesn't really matter how many resources you have, especially in this special population, but it's really important how to use them in order to get the best treatment management for your patients. With that, I really want to thank you for your attention. Thank you.